exciting things that are happening and exciting lineup for you today. Kicking off our morning plenary, we are excited to have Dr. Anisha Gandhi. Dr. Anisha Gandhi is the Acting Assistant Commissioner for the New York City Department of Health Bureau of HIV, where she oversees the city's response to the HIV epidemic. She also serves as the Bureau's Director of Racial Equity and Social Justice Initiatives. And she really has shown her focus on programs for women across the city of New York and trying to make sure that initiatives and efforts that are focused on women, particularly women of color, and our LGBTQ community are happening. We're very excited to have Dr. Anisha Gandhi, who's going to give us an update on women, girls, and it will include an update on how they've been impacted by the COVID response. So, Dr. Gandhi.
Thank you so much, Ingrid, and thank you to all of the organizers. It's wonderful to be here with all of you and see so many faces joining us today. I also miss the in-person event, which I've gone to over the past many years, but wonderful to be in virtual community as well. So I will just pull this up. Great. And happy to share with you this update on the state of HIV and COVID-19 among women and girls, knowing that we have both a New York City and a national audience. We'll share a little bit of data on both those fronts. And also wanted to acknowledge that as I'm coming to you from Manhattan, I acknowledge and pay gratitude to the Lenape people for their stewardship of this land for many generations. So to give you a quick roadmap, I'll share a little bit on the epidemiology of HIV in the US and New York City with our most recent publicly available data, and we'll do the same for COVID-19. And we'll highlight some of the structural inequities and COVID-19 vulnerabilities that are unique to women and talk through what that looks like and what we should be mindful of in relation to outcomes that may extend beyond just COVID cases. And I'll share also the some preliminary data we have that demonstrate the impact of COVID-19 on our HIV-related services here in New York City, as well as our progress toward ending the epidemic goals. And finally, we'll leave some time for questions and answers. So here in the United States, we have 1.2 million people aged 13 and older with HIV, and 24% of those are women. In 2018, we saw 38,000 new diagnoses of HIV nationally, and 19% of those occurred among women. And new diagnoses among cisgender women declined from 2014 to 2018, about 8%, but in that same time, we actually saw a modest increase among transgender women, adolescents, and adults. And as you can see with this map, we see that cases are not equally distributed. These are case rates across the country. And we know that 50% of new diagnoses are actually occurring in the South, with some of those highest case rates occurring in that area as well. And this data here is among cisgender women and girls. So it demonstrates that here in the green, you see the proportion of each of these racial or ethnic groups in terms of their distribution in the US population, and the purple bars is the proportion of new HIV diagnoses in 2018. So these aren't all lining up, and what is most marked is that new diagnoses are over-concentrated among Black and African American women, while white women make up much less of new diagnoses. Sorry about this, much less of the new diagnoses relative to their proportion of the US population. And within new diagnoses among transgender women in 2018, 49% occurred among Black or African American women, and 33% occurred among Hispanic and Latino women. I want to be really clear that these disparities are not indicative of differences in biology or behavior. Rather, these demonstrate the consequences of deeply rooted and persistent structural inequities and oppressions, including racism, xenophobia, sexism, transphobia, and others that limit people's access to quality HIV prevention and care, and limit their ability to achieve and maintain a full state of health. In New York City, I'll also share our 2018 data, and here I'll note that when we talk about results among women or what we've seen, that includes both cisgender and transgender women and young girls. In 2018, we saw 1,917 new diagnoses, which is the lowest number of new diagnoses we've seen since we began surveillance and reporting of these data in the early 2000s here in New York City. Of those new diagnoses, 430 or 22% occurred among women or girls. 76 of those 430 new diagnoses were concurrent HIV and AIDS diagnoses, or 18%. Which signifies that about 18% of those people had likely been living with HIV for quite some time before they were diagnosed. As is the case with our national data, most new diagnoses among women in New York City were attributed to transmission through sexual contact. And in 2018, it was the second year since we've started reporting these data, where we found no new perinatal transmissions, which is wonderful. In terms of our mortality data, we observed in 2018 510 deaths among women living with HIV and observed a higher death rate among women compared to men. So as you can see here, in the last 5 years, we observed quite a substantial drop, a 29% drop in the number of new diagnoses, which signifies that we are making progress toward our ending the epidemic goals. However, we know that this progress is not distributed evenly across our populations. So while in 2018, we saw almost a 20% drop in new diagnoses among men who have sex with men, we saw a much more modest drop among cisgender women at just 5%, and actually saw a modest increase among transgender people in terms of new diagnoses. And I'll highlight that we have many fewer cases among transgender individuals, so those changes are much more sensitive to kind of small numbers of change in the number of cases. In 2018, 90% of new diagnoses occurred among women, occurred among Black or Latina or Hispanic women. Across this entire time, Black women accounted for the majority of new diagnoses among women. Still, we have observed a trend in decreasing diagnoses among Black women, Latina and Hispanic women, white women, and Native American women over the last 5 years. Again, these differences that we see and are very much a result of structural inequities, not of biological or behavioral differences. Between 2014 and 2018, new diagnoses among women decreased in each age group. New diagnoses continue to be most concentrated among women aged 20 to 29 and 30 to 39. Here we show some select stages of the HIV care continuum, which demonstrates our progress in caring for people who are living with HIV so that they can live their fullest, healthiest lives. And we want all of these bars to be as close to 100% as possible. In recent years, UNAIDS set 90-90-90 goals, meaning that by 2020, 90% of all people living with HIV should know their status, 90% of all people diagnosed with HIV should be on treatment, and 90% of all people diagnosed with HIV on treatment should be virally suppressed. New York City was the first US city part of the Fast Track Cities initiative to hit this goal 2 years ahead of schedule. And we did reach this goal among women as well. I'll now share a little bit about where we are in terms of our COVID-19 pandemic in the United States with a focus on women and girls. So as of today, we have 7.4 million confirmed cases of COVID-19 and have observed 209,000 deaths nationwide related to this pandemic. Females account for 52% of all COVID-19 cases and 46% of deaths. We've observed 23,000 cases across the US among pregnant women. And like HIV, we know that COVID-19 is not evenly distributed in terms of geography, with higher case rates occurring among the South and in other places. I also want to highlight some of the other, what some people call shadow pandemics or parallel pandemics occurring as a result of COVID-19. The US Census Bureau began this year conducting household pulse surveys, which is an online survey conducted within 2-week periods among adults 18 and older. These data reflect results from the most recent pulse survey in September from a sample of nearly 93,000 adults recruited through emails or text messages. That survey found that 41% of women, compared to 34% of men, reported delaying or not getting medical care in the last 4 weeks because of the COVID-19 pandemic. 40% of women, compared to 32% of men, reported symptoms of anxiety disorder or depressive disorder in the last 7 days. 12% of women, compared to 7% of men, needed counseling or therapy in the last 4 weeks, but did not get it. So these are some of the ways that women are disproportionately impacted by COVID-19, even if that's not showing up exactly in cases or in hospitalizations or COVID-related mortality. Rather, women's burden may be showing up in them not being able to manage other existing symptoms or conditions, and especially in attending to their mental health needs. Here in New York City, we have some comparable trends. In late March, New York City was declared the COVID-19 epicenter of the United States. And those of you who are here knew what it was like to experience that emergency and that level of trauma and loss as our city and our state was put on pause. To date, we've seen 241,000 cases, over 59,000 hospitalizations, over 19,000 confirmed deaths, and another 4,600 probable deaths attributed to COVID-19 here in New York City. As you can see here, women have a lower case rate compared to men here in New York City, as is true nationwide. And that's also the case for hospitalization. So women have experienced a lower rate of hospitalizations in New York City and a lower death rate. This is an ongoing area of research, but these differences may be explained in part by biological and physiological differences between men and women, including potentially a more successful immune response in women, as well as the higher frequencies of underlying conditions and behavioral risk factors among men. Similar to HIV, we know that COVID-19 is not evenly distributed by race and ethnicity, neither in our national data nor in our local data. Here you see really pronounced differences in case rates by race ethnicity here in New York City. COVID case rates are about 1.5 times higher among Black and Latino or Hispanic people in New York City compared to white people, while hospitalization and death rates are twice as high among Black and Latino people compared to white people. Even though we've observed lower case hospitalization and death rates among women, again, those reports are strictly confined to COVID-related measures, and there are many structural inequities and unique vulnerabilities among women that we need to continue to monitor and be mindful of in terms of the thinking about really the kind of global burden that women face as a result of this pandemic and our local epidemics. For example, we know that our frontline workers are at greatest vulnerability in terms of their personal safety and their risk of acquisition and potentially being part of transmission chains. Women make up 63% of New York City's frontline workers. In fact, within our frontline workers, they are 74% of our healthcare workers and are 81% of our childcare, homeless, food, and family service workers. Again, these are often jobs that require face-to-face contact. Overall, 3/4 of our frontline workers in New York City are people of color, which means that women of color make up the biggest block of our frontline workers. We also know that women may have a smaller financial buffer when it comes to the effects of this pandemic. Women on the whole have lower incomes and are paid less. They are more likely to live in or near poverty. Women were disproportionately held the types of jobs that have been lost during the pandemic. They were hit hardest and earliest by layoffs in restaurants, retail, and in the healthcare industry. A Department of Labor report recently released, actually just last week, showed that 4 times more women compared to men dropped out of the labor force last month. In dual income households, women are often likely to be the lower earners, and regardless of whether they're in dual or income or single income households, they are more likely to leave paid employment for unpaid caregiving roles such as childcare or elder care or supporting children who are being schooled at home. Even before the pandemic, we had data to demonstrate that women shouldered the greater burden of household labor. In married households, women conducted nearly twice the amount of household chores compared to men, and women are now also shouldering a disproportionate amount of caregiving burden as well, with family members and others at home. Women are also then responsible for a lot of the emotional labor attached to caring for people, both physically and emotionally, throughout this pandemic. Women are also more impacted by restrictions in access to sexual and reproductive health services. We know that, especially at the beginning of this pandemic, many states limited abortion services, deeming them non-essential medical services, and placed tremendous amounts of restriction on labor and delivery care, and the ways that women could proceed with those in healthcare facilities. So all of these things have disproportionate impacts on women and threaten their ability to receive the care they need in a timely manner. We've also seen data to suggest that both locally and nationally, and actually even internationally, there have been increases in gender-based violence and domestic violence during the pandemic. Oftentimes women who otherwise would be able to go to work, to other places, seek support in shelters, may be less likely or less able to do that, especially while communal housing is under a greater threat of being hubs of transmission of the virus. Women may also be less able to seek safety, to make plans, or even to be able to seek support in situations of domestic or intimate partner violence within their homes, especially during times when our cities or our states are on lockdown. Women have also been the victims of, both directly and indirectly, of many forms of trauma throughout this pandemic, including but not limited to state-sanctioned violence against both cisgender and transgender women, which has not yet seen the complete carriage of justice. I'll share now a little bit about the impact of COVID-19 on HIV-related services here in New York City. So I want to note that we typically do a number of things to continue to track our HIV surveillance, and that includes both a lot of personal follow-up as well as monitoring, reporting of what we've received in our labs in terms of new diagnoses, and also tests conducted to maintain the health status of people living with HIV, including their viral loads and CD4 counts. And so being that we have gone to all remote purposes and are not able to do the same kind of record review in person at healthcare facilities, we have a much more limited ability to really be able to surveil what's going on with our epidemic right now, and so may not have kind of all that comprehensive report until next year, when we're really able to take a closer look at all of these data. However, I can show you here that in our 2019, you have our blue bars, 2020 in the red bars. You can see that in the same time periods or in the same months, we saw this year a really dramatic decline in the HIV-related laboratory tests. These are the positive HIV diagnostic tests. And so really when the first wave of the pandemic peaked here in New York City, we saw a tremendous decline in those in the volume of new HIV diagnostic tests, and a little bit of a rebound as we went into our summer months and facilities and the city began to reopen. And we see comparable kind of effects in relation to laboratory tests for people living with HIV, including their viral load and CD4 counts. So a steep decline in March and April with a little bit of a rebound in going into the summer months. I also want to share some reports that in terms of changes in utilization of HIV prevention services in our PlaySured network, which is a citywide network of HIV testing sites, community-based organizations, and clinics working together to promote patient-specific approaches to sexual health and HIV prevention, and is designed to increase access to PrEP and PEP and link people who test positive for HIV to care. So if a patient or client accesses services, whether they're related to HIV or not, any of these sites, our network is really designed to make sure that they have a warm handoff to whatever services they need, be it testing, prevention, including PEP and PrEP, linkage to HIV care, or other supportive services. And our PlaySure network sites are distributed throughout our priority areas across our boroughs. What we observed during this time was that, similar to those lab volumes you saw, that we saw a decline, especially this dramatic decline into April, in PlaySure network enrollments among our priority populations. And you see this really steep decline among Black and Latino women who have sex with men. We also saw a decline, though not quite as steep, in new PrEP initiations. What seemed to be less sensitive to changes during the pandemic were PrEP continuations or refills in PrEP prescriptions among people who had already initiated PrEP.
Dr. Gandhi, you have 5 minutes left in the session before.
Thank you. So our sexual health clinics continue to remain open, providing both HIV and reproductive health services. We've continued a lot of our community engagement with our community planning bodies, including our HIV planning group and planning council, New York Knows, and our Women's Advisory Board through virtual meetings, town halls, and a lot of specialized email digests, really supporting people more broadly through the pandemic and not just on topics related to HIV. We've also issued a number of public and provider-facing guidance on HIV care, PrEP and PEP, and safer sex, and have participated in virtual Pride events. We've done a lot to try to support our contracted providers who receive funding through us, shifting funding mechanisms, providing emergency funding so that people both living with and vulnerable to HIV could continue to receive the care they need and know where they can get either telehealth or in-person care. We also have we launched Door to Door, which is a mechanism through which New York City residents can order free safer sex products for home delivery, and have expanded our home test giveaway, partnering with over 60 community-based organizations, health centers, and clinics to distribute over 2,000 HIV self-tests to people at home since it launched in May 2020. And I want to acknowledge that even though we are struggling with the HIV epidemic as well as the COVID-19 pandemic, we are still conducting a lot of work toward ending the HIV epidemic, in part thanks to a lot of federal support through the Ending the HIV Epidemic, A Plan for America initiative, which launched last year. So we have a lot of new activities underway that are supporting women and girls specifically, but are designed to really support all of our populations in New York City and all of our communities, but with a particular emphasis on those most vulnerable to the impacts of HIV. And we would love to get community voices in an anonymous online survey. I will post the link in the chat and look forward to any of your participation for those of you living in New York City. So I want to acknowledge my colleagues in the Bureau of HIV who supported the information I'm sharing with you here today, and I'm happy to open it up for some questions and discussion. Thanks so much.
As a reminder, if you have questions for Dr. Gandhi, you can type them into the chat box. The chat box is at the bottom of your screen. Dr. Gandhi, thanks so much for that great presentation and that update. And I think it's a definite tie into what Dr. Jones is going to be talking about later. But I think it was interesting to see how we continue to see how women bear the burden of, here we are in a pandemic and women bear the burden, whether that be financially, whether that be in how they care for their children, whether that be with the burden of HIV diagnosis, because women are the caregivers of their family. So we know that once the mother is sick, the family is sick.
Yeah, and I think it will be really important to track the ways that that those impacts show up, not only in what we see with COVID-19, but a lot of kind of parallel occurring illnesses, both physical and mental and behavioral. So yeah, we'll need to take care of our women.
I think Mike had a question that he's going to present to you. Oh, I'm sorry. It was only sent to me. I thought it was sent to everyone. So the question is, has the Department of Health set specific targets to decrease incidence of HIV among Black and Latino women?
We have, and we actually are in the place of renewing and updating those metrics with our colleagues at the New York State Department of Health AIDS Institute. So we do set specific targets, not only for reducing infections, but around specific indicators for prevention and care as well, including PrEP uptake. So stay tuned, because we will be sharing more of those for 2020 and beyond in the coming months.
Wonderful. The other question that came is, do you have any information on the intersection of COVID and HIV?
Yes, I wasn't able to share it here. We are working on a match to really look at that with a lot of different data, with people living with HIV with and without COVID, and people who have become COVID positive, both living with and without HIV. And so we expect to be able to share and release that very shortly. And I'm happy to share that with you, Ingrid, for distribution once that's out. I imagine it should be out very soon.
Great, wonderful. Another question came about, are there slight increases in HIV in older women, between the different populations, but have we been seeing, I guess, slight increases in HIV in older women?
I will go back and check, and happy to report that back into the chat. I think we continue to monitor this, and especially given that our population, our older population is growing, that's living with HIV. And like we also know that older people may be more vulnerable because they're not getting this kind of sexual health services and their prevention needs attended to. So we have a number of initiatives kind of focused on that, but happy to reply back to that in the chat in terms of whether we're seeing increasing trends there of new diagnoses.
Okay. And again, everyone, we may not get to all of the questions, but one person, I thought this is a great one. If people have wondered if the suicide rates have increased.
Among people living with HIV, or just generally?
I guess in general since COVID.
Oh, that's something in both nationally and locally, I'm not as familiar with, but happy to look into and see what I can find as well.
Okay, great. And do we know if there's any false positive data, or data on false positive rates for New York City COVID testing?
Oh, that also I'm less familiar with, but I can tell you that for any organization interested, I know our Test and Trace Core is really eager to continue connecting with community organizations, individual groups, and so they are very happy to report back on that with the most up-to-date data. I know that they're keeping very regular track of what that testing data is looking like citywide.
Okay. Mike, do we have time for more questions?
No, I think, excuse me, our session is up.
Okay. We had a couple more questions in the chat box, but we will try our best to present those to Dr. Gandhi so that she can answer later. I think, one good one that came up, Dr. Gandhi, we'd love to hear your reply to as a final question. There's a concern that we'll see a decrease in federal support around the National HIV and AIDS strategy, and what implications will that have for our In the Epidemic initiatives?
Sure. I can tell you now that I think we were really fortunate for this to be a major initiative in 2019. And so New York City has been very fortunate to actually receive an infusion of federal funds that will continue. That I think that as far as we know, those are somewhat secure, and a lot of new activity is actually underway to be able to support our ending the epidemic work. So we will kind of continue to see, but we will do our best to maintain our progress toward ending the epidemic.
All right. Wonderful. Everybody can join me. There's a reactions button on the bottom of the screen. So let's just give a huge thank you to Dr. Gandhi for a great presentation. There's a lot of, you probably haven't seen it, Dr. Gandhi, because there's a lot of reaction in the chat box saying thank you, fabulous presentation. So let's all give thumbs up and applause. You can do that through the little reactions button on the bottom of your screen. So we thank you again for coming on today and for participating with us. And we're, you know, you see, hopefully you can see, if you see the people's screens, you can see all the thumbs going up in the celebratory remarks that are coming through there.
Thank you. It's a pleasure and an honor to be here with you all. Thanks.
Great. And then what I'm going to do is we're going to open up the chat box also that you can then chat with everyone, and she can also see your messages and your thank yous through the chat box as well. So thank you, Dr. Gandhi.
Pleasure.
All right.